Okay, so we're going to do something slightly different today. I've got a radiologist with me, and he is protecting his identity to a certain extent, because there are some sensitivity reasons for that. Um, but in a hilarious joke, we're calling him Ray today. Um, and usually I give a background to my guest, but today I'm going to ask Ray to explain his background and tell you more about himself. So firstly, thank you for joining me.
Thanks for inviting me.
No problem. So yeah, could you give the viewers a little background on yourself, please?
Yeah, so I'm a general radiologist, a generalist qualified in the mid to late 1970s, and I was a GP trainee and a principal for 4 years before I became a radiologist. And again, I carried on the general theme by doing my general radiology training and becoming a general radiologist with interests in some posts over uh, quite a number of years, decades, years wide general experience in all the main clinical radiology specialisms, so chest, abdomen, musculoskeletal, radiological, obstetric, gynecological, and pediatric. And I was mainly a visiting radiologist in the team at the neonatal unit for 1 to 3 times a week, but certainly not a specialist in any form. Um, Owing to some building removals and new build, I was left to help out with doing a long-term locum with the neonatal unit for that period. But I had been doing that for 10 years as an interest in a previous post. So I'm full-time NHS clinical practice. I do occasional medical legal reporting. I don't promote myself for it. I'm only sought out and I agree if there's some learning involved for me and that it's appropriate for my experience to do that. I've only authored about 8 or 9 papers because I'm not really academically um, inclined. Um, my most, I think my most valuable paper is actually the unpublished one. I'll tell you more about that later. But
Okay.
as a powerful audit in its own right, it was something that I spent an awful lot of time on. I mean, it was inordinate the amount of time that I spent on that, which included 500 reports, followed up at 1 year, and then written up, and in a quite a detailed process, which, not being academic, was uh, a sort of baptism of fire into a proper study, if you like. Um, so obviously doing some honorary senior lecturer status with some of the posts, but really I enjoy teaching and one-to-one with patients. That's the best aspect of my job. I like to talk to the patients beforehand. You don't always get the history. I like to put them at their ease, and at the end, I like to tell them what's going on so that they understand everything. And when you get your appraisal, you get asked sorts of questions, and the killer question usually is, what do you like most about your job, or what don't you like, or what's the worst aspect of your job? So it's easy for me. It's when a patient comes in and is angry or aggressive, and it's usually because they're worried. They're coming in for a test, and they're going to get a scan. And I think this is the best part of my job. Um, I don't think anybody's left unhappy. They know they're getting attention, and they're getting full professional attention to what's wrong with them, and I hopefully make them understand the significance of what I've been doing, and generally try to give them a reassuring result. Obviously, that's not always possible, but a lot of time it is. So, so that's basically my background.
Yes,
Um,
we're going to do a presentation on the Lucy Letby case today and on air embolism generally. But before we go into that, can I just ask you how you became interested in Lucy's case?
yeah, sure. Um, well, it was really I was aware of the drama to do with the post office scandal and the role of private eye in unearthing that and going some way towards restitution process, which is still ongoing. and very, very slow. But when I heard that Private Eye were looking at it, I thought interest was piqued a little bit. But then when Xu Li and his team of experts burst onto the scene, and given the description of what they did, and to be honest, Xu Li and his outrage at how his paper was used is really a catalyst for all the things that have gone on subsequently, and the degree of publicity that's been raised by it. So that was the first time really when that publicity was made about the world experts.
Yeah,
looking at things again.
absolutely. So obviously this is your area of expertise, although you're a generalist as well. So you're going to go through various slides and papers with us today. So I just want viewers to know that this is tricky for me as well. I don't have any knowledge or certainly no expertise in this area. So we're going to go through everything slowly. And I'm going to let Ray speak as much as possible. But if I feel I need to ask a question, then I will. But I'm basically going to let him speak as much as I can. So let's fire away. Let's go.
Okay, so interesting one to start with. This is an image and done an ultrasound, and I wonder if you can possibly work out what it's showing.
So I was looking at this. Obviously, we've had it on the screen for a while now, and I would struggle to give a good answer to that question, I think. I mean, I haven't got a clue.
Okay, so you're not alone in that. I often put this up as the first slide when I'm giving my pre-exam preparation talk to our first-year trainees now. This is after they've done their study. They've been working in the department for about 6 months and they've experienced lots of modalities and things. And there might be one out of a bunch of maybe 10 who'll maybe get it. And also, I was using AI last night, and I asked the AI if we could make a sketch of this image, and it was still whirring away 15 to 20 minutes later. So I put it out of its misery and stopped, and I did a sketch just to accompany it. And I wonder if you can guess what it is now when you see the sketch.
I'm not very good at this kind of thing.
No, right? Okay, that's fine.
So that looks, I mean,
So
that looks more like an infant's head now.
it is indeed. It's a fetal head.
I can see it now. Now
Yeah.
in ultrasound now I can see.
And can you see the? Can you see the?
I was more focused on this bit. Obviously, that must be the esophagus, or is it? Is the bit?
Is it this bit you mean?
No, to the right of where you are now.
This
Yeah.
bit?
So that I was.
No, no, that's interesting. You've obviously seen the you've previously seen the statue of the thinker, haven't you?
Yeah.
And where it's I think his fist is on his forehead, if I remember correctly.
So
But
that's
in this instance, what you've got here is like it's like a Peanuts cartoon. I don't know if you remember the character Lucy.
yes.
And she was always listening to Schroeder playing the piano. So she was sitting at the edge of the piano with her hand under her
Yeah.
chin,
Yeah.
listening intently to Schroeder playing. So that's what that shows. That's
Okay.
baby's fist underneath the chin,
Right.
and it's the forearm that you see going down there.
Right.
And you can see the bones are quite white underneath the face, but the skin of the baby or the fetus, really, to be honest, is the outer layer there, and you can see that there's a pout going on. There's a bit of a kiss
Mm.
going on. So
Mm.
it's a kissing thinker pose, if you like. If you were putting, if you were Van Gogh and you were putting a title to it, that's what you would put down.
Okay.
But it's more interesting than that even. So if you look at what it's kissing, and that is the afterbirth, the placenta. So
Okay.
this is the baby's oxygen tank.
Right.
So baby's very happy to have its oxygen tank and to be living in its own comfy environment inside the womb. And that hopefully up until term, that's what would be going on. Baby would just be growing through the placenta, being nourished through the placenta, having all its biological needs basically served through the placenta. and until the moment it's born, fluid will rush out, and baby will be born, the placenta will detach, and lots of changes will happen in the baby. One circulation will become two, or things will open and things will close, and baby will take its first breath, so the lungs will be inflated for the first time. And the whole circulation changes, and nobody goes in and stitches up the changes in the circulation. So there are lots of potential areas where circulation can keep flowing maybe abnormally for a while, or take a while to go, or it might be going in the wrong direction. But it's really quite a complex process. But by that method, we're all born, and I just thought it was a nice image to contrast against what happens when that goes wrong.
Yeah.
Which is the next image. Sorry, that was really just to show the without my sketching efforts.
Very
that's the next image, and this is when it goes wrong. So this baby should be a fetus, but you can see that there's all sorts of life support going on here.
Yeah.
And it starts from the top with the intubation and the ventilation that's on there. I've cut it off just to sort of not show too much of baby, just to try and concentrate on the life support. Now, I have to say, I saw a picture like this when I was scanning a baby a few days before that, and this baby had twice as much as this in the incubator. That bundle of wires and lines was twice as big as that, but that's what struck me when I looked at it, and I just thought, my goodness, this picture's got it's telling quite a story about what's required to keep babies healthy.
I think so. What I would reflect on immediately is that this is normal for you, but if you're a parent seeing this and seeing your baby strapped to all this stuff, it must be pretty alarming.
Well, that's what I thought too. I basically, it rocked me looking at it because I was aware of all the things, and it was so dramatic looking at the previous one that I thought that I began to think, yeah, that's all tied in with what's happening in this farrago of misadventure that's going on. People aren't understanding what the basic processes are here and what would happen normally, as against to what you need to do, is required to do, to monitor, to treat, to put fluid in, to put nutrition in. And all that's done by a team of people, huge team of people. So I've sort of jumped on a bit from what I meant to do. I'll come back to the image and give more narrative, if you like, of what it means. And after a couple of days thinking about it, I asked the charge nurse if I could have a picture just of the lines, to give for a presentation. So she gave me a number of images, and I've cropped away. But the biggest thing is that the baby, from the neck to baby's bottom, is only 5 inches long.
Yeah.
And the tape measure was just above the baby, so I took that off. But it just shows you what's required at 26 weeks. And some of the babies that were in that unit that we're all talking about were at that gestation. And did they have all this? So anyway, I'll come back to that, as I say, and I'll go through the radiology bit of it.
Yeah.
And how obviously over a period of decades, our lives as radiologists have changed drastically. The complexity of things that we do now is just enormous. The different specialisms within radiology even. And they still require generalists, because a lot of work is still general work. But we do have our own kind of sub-special interests, and obviously I've got a wee bit of one there, and some other things, and they've changed over the years, but I just thought I would give my own personal account of change, how it fits in with the framework of the college and radiology in general, and then compare that with how well other systems are doing or not doing. So we'll deal with the images of this circumstance first.
Yes.
And it's important to realise there's several caveats. The only image that I've seen is the one in the famous Lee and Tanswell paper, where, and I have to give caveats, I've not seen, it's taken out of one case within a paper that dealt with a number of cases, so don't have any clinical history, have to make assumptions about biology, and basically humans are triploblastic, which means they've got they're derived from 3 germ layers, and it means that there's cavities. We have cavities all over the body, and those are potential passages for air or fluids to move. I suppose an air is a gas, and a gas is a liquid by definition, but not only the compartments, but when I think about showing blood vessels, which we're obviously going to do, the way that the study for that is called angiography. An angion in Greek means a container. So these are containers of blood, and there's different systems. So basically, and as I say, there are obviously fetal remnants which complicate from the usual adult system. But we'll talk through the image now. I've been trying for the last few days to get permission to show the image in the paper, but finally got another email saying I have to do something else to try and apply for it. So what we're going to do is there is open access to this, so anybody can get the X-ray. But as I say, I don't have the permission to show it in a presentation. And to protect yourself, I think it's wise that we do that. So if anybody's interested in the radiology, if they want to stop the video there and go into the more section and look for the reference for the Lee and Tanswell paper and just find the image, and if you can try and download it, it's quite straightforward. It's all set up for you, and you can put it on one side of the screen and produce your video to the other, and hopefully get a bit of a comparison. But what I've done is I've drawn a sketch of it. Had a battle with AI last night trying to get AI to draw sketches of images and vice versa. But that first image, I don't know if I said, but the AI was whirring for 15-20 minutes and couldn't get the answer. Couldn't draw a sketch of that image. So first thing to do is to show the sketch. Now, what I've done is I've drawn an anatomical labeled diagram on the left-hand side of the venous system of the body. And everybody's aware of what their veins are. Now, although they're called systemic veins, the whole venous system is like a branch of trees. Now, it's 2 trees. There's one from the top of the body and one from the bottom of the body, coming towards the right atrium. The right atrium is the common chamber, and that's basically in the pulmonary circulation. So the venous system, the systemic venous system, is the preload chamber for the pulmonary vasculature. So the blood there will be pumped, not pumped, but it will run into the right ventricle, where it will be pumped straight into the lungs, and in the adult oxygenated. So what we have here is there's a sort of, it's like a stick figure or a stick man in the middle. And I was trying to find the word that described what this is actually showing. And I was aware of what I was trying to describe. So I went on Google and tried to find out what they're called. But I don't know if you've ever been to football matches where they have these stick figures that are about 20 feet high and they blow around and they move because you're pumping air into them. And they're actually called air dancers. I didn't realise what that's what they were called. But if you've got £1,000, you can buy a good one and have a display of the air going round. But what's happening in this is completely like an air dancer, but it's a very pathological condition because you shouldn't be able to see the veins of the body on the X-ray, but in this instance, you do see them at the right-hand side of the image, and that indicates that there's a lot of air in the vessels, which is obviously grossly abnormal. Now, the normal flow of the blood flow is, as mentioned, is as described on that arrow. So at the lower part of the body, or the inferior part of the body, there's a main vein that drains up towards the heart. And at the top, there's a superior vena cava, which drains down towards the heart, down to the right atrium, the common chamber. And in this instance, there is no way that the air is coming in the direction of the arrow. It's got to be coming retrograde, because the air would then have to be flowing through all the tissues of the body and somehow get into the venous system and come up that way. I mean, that's just physiologically, I think, impossible. So what we've got here is air blowing back down the main venous system. And this is the image that's described in the, that I'm describing of the X-ray in the Lee Tanswell paper. So what you've got also is the two limbs at the bottom go to the legs. So the air has been forced down as far as the pelvis. And it's also going into the kidney veins, the renal veins. You can see them as the arms of the stick man. And there's a kind of rasta appearance at the top, or a crow's feet appearance of air in the liver vessels, the liver veins. So, and the structure in the middle, which looks a bit like a head, is really just a metallic artifact from a sensor on the baby's body. And then as you go up to the heart bulge above that, you'll see I've marked a cross-hatched area, which is black on the X-ray. And what's happening there is the air has blown back into the right atrium and also gone through the valve there into the right ventricle. And the likely destination for all that air is going to be the lungs. It'll go through the pulmonary arteries then and into the lungs. And I've got some adult cases to show following this. But that's the basic images, or the basic interpretation of the image of the Lee and Tanswell paper. There are other aspects to it, and I'll mention it. But if I go on to the next one, and air embolism was the preferred diagnosis for sudden collapse in the babies that were at this hospital. And I think that's just symptomatic. It's not pathologic at all. It's not definitive.
Can you explain the difference between the two, please?
Between
symptomatic and pathological?
All right. So basically, symptomatic means it's in the surface. You know, it's a peripheral way of looking at something, whereas pathological means that you've probably dug into the real causes of things, which, as I say, will become evident, what I think, later.
So with just to clarify, so with air embolism, you're just looking at the external. Oh, look, there's obviously the key things here are rashes and discoloration.
Yeah.
Even though Dewi Evans claims to have diagnosed it without seeing the rashes and discoloration, but that's a side issue. But you're not looking at the physiology, you're just looking at symptoms, basically.
Yes. I mean, there's all sorts of discussion about where the rashes came from, and one possible explanation is, I mean, those vessels are too deep to see. Those are in the middle of the body, the inferior vena cava. But if you have a lot of gas in a peripheral vein, then you might be able to see. It's like it's actually called the vena cava. It's a cave. And in this instance, the cave is filled with air, and there's a very small stream of blood probably within that, running like a stream. Instead of filling the whole vein, it's only a stream at the bottom of a cavernous air-filled structure now. And it might, if you saw that in a superficial vein, it might look like a very thin vein against a pale background. But I don't think that's anything really to do with the rash. I don't know that the rash can be explained as straightforwardly as that, but it might be something in an odd circumstance where you might get a small pink vessel in a pale background, but that would be kind of speculation, I think, at the moment. So this is I don't know if you can see that because it's coming on to my, but there's an arrow pointing here. This is a CT scan, and a lot of the time when you have a CT scan, it's either some injection of contrast or there isn't. If you don't need contrast, they won't give you it. But they'll give you an injection of contrast via a machine, and it'll be something like 100 mils of contrast. It's quite a lot. Or in the next instance that's coming along, it was actually 150 mils of contrast. And that's power injected into a vein in the arm usually. And what you've got here is you can see a dark column on top of a white column further down, going towards the bones of the shoulder. And this is air in the brachial vein, which is just the arm vein, just a posh name for the arm vein. And what's happening is it's layering because it's a bit like what you would see in a spirit level. You've got a bubble of air on top of fluid. So even though there's pressure injecting it, it's still bubbling back to the top because the arms are usually held over the head when you have your CT injection. So most of the air quite a lot of the air is still in the arm just because of gravity. So and then because you're actually on a CT scanner, you have instant diagnosis and quantification. It couldn't be any more fortuitous. You know, there's been a problem at the injector. Probably there's a wee bit of a loose connection or something, and some air has been injected, and you've been able to diagnose it, not infrequently. And there's lots of cases in the literature of it. Well, the patient's actually on the scanner, so you're actually causing the problem, but diagnosing it at the same time. So you're actually having. It's not like somebody's presented to the A&E department. They've got something. You have to wait until it's requested and the scanner's free and warmed up, and then somebody does the examination. This is real time. This is happening, and the next one. So just to give you orientation, this is the spine here. That's the arms there, and that's the first rib, I think. And this is the windpipe here, and this is the vessel that's going to join up with that vessel. And you go back to that diagram of the venous system. That's the upper branches. So the arm veins and the neck veins will join at the root of the neck and go down into the chest. So and that'll become the superior vena cava, which we've already seen on the diagram. So when it gets to the heart, then now we're just following this down. So we're going into the chest now, and that's the pathway it's taking. So it's come down the superior vena cava, and the air is now sort of bubbled to the top because the patient's lying flat in the machine. So this is the dependent part below, and that's the non-dependent part above. So the air is in the non-dependent part here, and this is the tricuspid valve here. So the passage of blood will normally be into the right atrium, into the right ventricle, and into the lungs, and that's the pulmonary. That's the pulmonary circulation. So so there's some air here. And I think what you've shown in the Lee and Tanswell paper is that this is the air here that's actually shown in our case, which actually resolved without anyone knowing that there was anything wrong. And there was no treatment given or required because I don't think it was picked up until it was an outpatient. So it wasn't picked up until it was reported, which could be several days or a week later. So there was no untoward side effect from that. So it's important to know that. And it's also important to know that the next patient also survived. They were intubated for a couple of days, but they survived with no ill effect whatsoever. No residual effect, sorry. And so this is the breastbone here, and the heart's underneath. the breastbone, and it's a bit like a St Andrew's cross here. You've got 4 divisions for different chambers, but the right and the left, sorry, the right and the left are separated by a wall. There is a hole here that closes when baby's born, called the foramen ovale, and you've probably heard about that. Some air sometimes escapes into the left side of the circulation, and that's when you worry, because it's going out to the brain, it's going out to the major organs in the arterial system. But it doesn't happen in the adults unless there's a patent one, and that's fortunately quite rare, or not uncommon. Sorry, not common.
Yeah.
So air has trickled past the tricuspid valve, and this was our case, and it was reported, as I say, just incidentally it happened, and there was no untoward effect. But it's a demonstration of it shouldn't happen, but it does, and we try and be careful, more careful each time. And I know Lucy Letby was very keen on the DATIC system, and doctors aren't that keen on the DATIC system, because if I report that, or if that was reported by me now, in 10 years' time, or 10 years previously, you'll find that there was probably something similar reported. So although it helps maybe for a short time and things tighten up, it's the system that needs to cure. But anyway, we'll talk more about systematic things as we go on.
Okay.
So the reference here is a case. Somebody hadn't filled the syringe at all with contrast. There was no fluid. The iodine contrast that shows up as white that you saw in that image was not in the actual canister, so it was just air that was in it, and it was pressure injected into the patient. So it was 150 mils of air, so that's an exact dollop of air that's going in. Couldn't be more precise. So the patient had just a general management, and it was intubated for 2 days. There was no pressure chamber. They weren't treated for the bends or anything like that. And they were well afterwards. But it's still a never event. I mean,
could you just define what a never event is, please?
A never event is like, somebody going in for an operation, and it was, say, an amputation of the right leg, and the left leg was amputated. That's a never event, something that should never happen.
Right.
So that should have been checked. And what you normally do is you check the tubing for air bubbles, and we're all quite fastidious about that, and join it up. So somebody somewhere just lifted the tubing and attached it to the thing, and then they forgot to fill the reservoir with contrast. So I don't, it's one of those things, you wonder how that happened, but it did. It was a never event. So, and then there was one in the paper of it happening a repeated time, not with this case, but there was one said it repeated. So as I say, the DATIC is only so good. It depends who's at the other end of it affecting change. Is there effective change going on? If you don't have the right, let's say, environment of change and improvement, sometimes you're just logging things and nothing's being done. But anyway, come to that. So this is the computer sketching out a CT for me. So there's air in the ventricle here, quite a lot of air, much more than was in that previous one, and some air here as well. I don't know exactly where that was. But the actual image was very noisy, and yet the computer did made a quite good fist of it. And so that was at the ventricle level. Now, what happens, the ventricle is under your sternum, and the pathway for it, the outflow tract, goes up the way. So it goes across from your right atrium through the tricuspid valve in that St Andrew's cross arrangement to the front chamber, and that gets pumped up immediately, and then it takes a 90-degree curve back towards the center of the body, and then divides into two, the right and the left pulmonary arteries, which I'm now going to show you. So this is just a sketch map just to say I'm just highlighting the things. But in this instance, it's the pulmonary arteries that are the air dancer, not the veins. It's got further along. There's been so much of it injected, it's just overwhelmed any gravity effect, and it's gone in an embolus, and embolus just means a dollop, into the so this is a computer generated image of it, and I've added in the air that was shown roughly how it corresponds. Just make it simpler because it was a very noisy image, lots of distractions on it. And so this is the pulmonary artery here. So this is it coming up under the sternum here, and then turning 90 degrees to go back towards the spine here, and then dividing into two. Nature's branching, I mean, trees branch, roots branch, arterial trees branch, everything's branching. So this was air filled all the way through, completely unnatural. And it was then sent out in the branching tree of the pulmonary arteries towards the alveoli. Everyone remembers from their high school biology, the alveoli with the blood vessels doing gas exchange across a very thin membrane. And that's how you oxygenate your lungs. But obviously this is going to be very pathological and overwhelm the system. When I was looking at the image, I wondered if there was actually some coming back in the pulmonary veins, but no one's actually given, I haven't looked at this that often because it's only because of this that I've looked at it recently, but I've never seen anybody demonstrate the air going through the capillaries and then back into the heart again. It would come in the left atrium that I showed you the last time, is the chamber at the back beside the spine. And no one's actually, I haven't seen in the few cases or papers that I've looked at, I haven't seen that happen or that be demonstrated. So I presume the air hangs around the capillaries, which are only microns in diameter, but it's a vast surface area. That's obviously nature's way of providing lots of oxygen, is to give a huge surface area. But anyway, it's now sent out into the lungs in quite a big package. And just incidentally, that's the treatment position for air embolism. So you just use gravity. So you put the patient on the left side, and then the air bubbles up, stays here. It doesn't go into the heart and doesn't go into the circulation. So just turning the patient onto the left side, and probably oxygen treatment, and depending on the amount of volume, whether other things are required, like chamber for the bends or things like that. So those, this is another reference really to show that there's a large, because you asked about whether or not what the causes of air embolism were and whether it was uncommon, and it's commoner than you think. And as I say, a lot of it is procedural, and most of the causes are procedural, but there are some very novel causes, some very adult causes of it as well. But there is a list that you'll get in the reference if you want to see it. But it's it's just a case of going through a list that's mainly of procedures, operations, injections. Sometimes even just an injection in the vein in the neck, you get air embolism. Somebody was walking about with a parenteral nutrition bag and tripped, and it must have ripped and gone into the blood vessel, and they got air embolism. So there's all sorts of things that are weird and wonderful ways to get it. But just going on to basically how radiology is adapted to change and changed its emphasis. When I first started in radiology, no one admitted to change. I mean, there's one or two people still a bit reluctant to admit to discrepancy or variation or error, however you want to put it. But nowadays it's all changed. If you went to an interview today for a job and you said, "I never make any mistakes," you'd be gently shown the door. I think so. I think the college we all have in the college have learned to change our outlook totally, 180 degree switch from what went on previously. So anyway, this is a famous illusion, and basically what it describes is your eyes are telling you that those two lines, horizontal lines, are different sizes.
Yeah.
But they're not, they're the same size. Okay? But that's because of the following. So our eyes are a product of 500 million years of evolution. I mean, I'm not just talking about amoeba, I'm talking about there was, invertebrates, and then there was 500 million years of further evolution. But in the Cambrian explosion, attack and defense mechanisms flourished and evolved. And you only have to see today, you look at Ukraine, whether it's fighting on the battlefield or with drones, and somebody's got an anti-drone this, and somebody's got electronic warfare, and somebody's got everybody's sort of trying to fight or flight, if you like, even today. So the eyes are simple photosensitive cells and limpets, and all they do is if they're on a rock and the light darkens, then their hold-on muscle contracts. They know that somebody's in the vicinity, and it's a survival mechanism. So squids and octopuses have got complex eyes, and even you go way back, and this is a wee rabbit hole I'm going down. This is to do with the way that this diagnosis of factitious or inflicted harm is so wrong, and how things are a common pathway. So if we go back to, well, I'll finish that bit, but we are hardwired to fight or flight, not interpret. We weren't born to read X-rays or read that image that I asked you if you could sort of interpret.
Yeah.
So going way back, endosymbiosis. So we teamed up our amoeba, probably floating around, doing a bit of fermentation, and not doing very much. Phagocytosed a bacterium, and symbiosis emerged. We gave, or the cell gave the mitochondria the means to survive, and the mitochondria had an ingenious way of doing oxidative phosphorylation, which keeps all our cells going. When you look at the biology of our cells and the DNA, the enzymes that are made all the time, and the speed that these things are rattled off at, then you realize that we need so much energy to go on. And I think Dr. McConville did a really good presentation of oxidative phosphorylation and how acidosis, hypoxia leads to acidosis, and that switches off the oxidative phosphorylation to cells, and basically you're then dying. That's you know, you're in a process, a downhill process, and once your adaptation reserve has gone, you reach a point of no return. And the reason for that is your oxidative phosphorylation is switched off, and your energy abilities are down to 1/36 of what they were, and you can't survive on that. So I just wanted to mention that as well. It's just basic biology, because a lot of things are taking things to things. So we then realized that there was a paper by Robinson that I'm going to comment on, who was a professor in Leeds, and he did a review of what he called radiology's Achilles heel, which is variation and error when we make mistakes because of various reasons. And he did this paper that basically transported quite a lot of evidence that was available in America to the British side, and did an excellent review on things that we should look out for. And the college took that up as well. Our college took that up, and they came out with a thing, like a statement paper that said to err is human, which is fine. You know, it's just admitting that you can make mistakes, but what can you do to improve so that you don't make mistakes? That's, you know, taking it on that step further is what sort of followed on from that. So a discrepancy occurred, say you do a CT and you see that air in the vessels, and you look back at the X-ray and you think, oh, there it was there actually. but it's a lot harder to see because it's a much more difficult image to interpret. But was that something that was okay for you to miss in terms of it was too difficult to see? Or is it something that you should have seen and flagged up? That sort of thing. So not all discrepancies are errors, but we often find discrepancies because we've got different ways of examining things now. And so I then got asked to do the audit lead in our department, and I thought, well, this and that involved doing the discrepancy department. And I thought, well, this will be a doddle because I know my colleagues are all super radiologists, and I wouldn't have that much to do. And I got a bit of an eye opener because when you actually look at the figures that we have for examinations going through, I mean, it was hundreds of thousands, 500,000 cases a year going through our various departments. So there would obviously be discrepancies among them, and I soon got busy with the business of trying to sort them out, trying to learn from things. And we have this confidential meeting, everything's anonymized, and it's basically, that's evolved as well to be it's now called a learning meeting. And it's got to the stage now where the scientific meeting for the college, there used to be, you would go and there'd be lectures on how to diagnose all these conditions, and there'd be various streams. There would be streams for specialists in different areas. And the whole meeting one year in Liverpool was taken on with discrepancy and learning from discrepancies, and being, trying to be clever about finding out ways that you could prevent, strengthen up your weaknesses. So when I read his paper, there was a couple of things that interested me. One, tucked away in the training bit, he mentioned about structural survey of the X-ray. So that's a bit like making a checklist of it. That was frowned on by the old-fashioned ones. Oh, we don't need that. Well, actually, X-rays evolved to CT scans and very complex things, and checklists are a very useful way. And most of our trainees at night now use checklists, and they go through the images with that in mind. They go back and forward, back and forward, back and forward, and double check. And then the consultant will verify it, read through it again, and check it in the morning. And the other thing is a double read, and that halves the error rate as well. But we're talking in terms of an explosion in imaging. So Professor Robinson was pointing out that CT scans, we were getting as many as 70 images per case. But now you get 2,000, 3,000 images, and you have to look at them at 5 different settings. So you're looking at 10,000 images for one CT scan. And that's, that's like somebody who has a couple of phases. They're looking at the arterial phase, they're looking at the venous phase, and the portal phase as well, just to build up a triple phase through all the vascular phases that contrast would go through. But that's not unusual to get thousands and thousands of images to scroll through. But what that also did was that proliferation of CT gave us a gold standard for the plain examinations, the chest X-rays and the X-rays of the limbs and all the other examinations, which still to this day make up the vast majority of examinations that are done in X-ray departments. So there was a gold standard that we could use. So I kind of harnessed that, and I went over to a big European meeting in Vienna. I was thinking it was the first time I'd gone, and I was coming over with a poster and giving several cases that we'd missed the diagnosis in, and that was quite in retrospect, it's quite a brave thing to do. You go and you tell the best people in Europe how you're making mistakes, but hopefully I was telling them how I was trying to improve and look at my weaknesses. As I say, so I looked at 500 cases, and yes, a half error rate. I think I was very strict about it. So it's something like 17%, say, and I halved that to 8%. Because I was double reading, I was bringing in abnormalities that I was over diagnosing. because I was looking at things twice. So anyway, so got it down to half, and I didn't know whether it was significant. And this is where statistics come in. And I knew basically statistics is a specialized area. I wasn't going to get access to statistics, being an NHS consultant and not having any connection formally with the university. Didn't have access to statistical packages or anything like that. But anyway, I spoke to one of the chaps at university who did do the statistical variation, the statistical study, and he discovered by a very strange test that it was highly significant improvement that was being made. And when I'd taken the poster, I hadn't had the statistical thing done. So I said that we were going to look at it, but I wasn't sure whether it was statistically significant. But in the subsequent paper that the college wouldn't publish, I think because we were short of staff to do things, politically that would have been a difficult thing to admit to. But now, as I say, their whole scientific meeting's taken over with, checking and double checking.
So before we go any further,
yeah, sure.
What would immediately stand out to me from this section is that we can surmise that the Countess of Chester was very bad at assessing its discrepancies and mistakes. Would you agree with that?
Well, I was going to mention it at the end, but
right.
Okay. we do appraisals yearly, and like for example, my appraisal, you do a professional development plan, and you highlight things. Appraisal I look at as a way of doing better next year, something to improve next year. And I highlighted that we were a bit weak in some disability provision. And that was very significant in 2 of the sessions that I was doing, because the patients needed to be undressed, then dress and go to the toilet and go through a waiting room to this, and then come back again and be examined, undress again and go exam. So you can imagine that would be, for somebody with a disability, that's a difficult area. So that, appraisal should be working out things like that. And when you listen to Michelle, who was a very experienced practitioner, would know all these things. You would know the difficulties that were happening on the unit. And she could have been, they were actually excluding them. I think they were divesting themselves of experienced practitioners. And those are the people who would be able to look at things coolly and say, oh, we're not doing very well there, or that's not terribly good, because they've all been designed in anyway. They happened, they actually exist in the first place, so they haven't been properly planned to start with. So that's what I would say about that. What happened to all the appraisals? There must have been, it was what, 8 consultants, and they were all appraised, and not only that, but all the neonatal staff were being appraised. Were they not sort of saying, hang on a minute, and then eventually, college report came out, and was any of that in any of the appraisals?
I don't know.
I think that's a pertinent question.
Yes. I mean, it's fairly extraordinary that this has been excluded from the court process when these weren't trivial problems or trivial recommendations the report was making. These were very serious. And they just seems to have been removed completely from any reflection.
Well, it's a 700-page report, and it was absolutely vital because somebody senior in the nursing could have taken it and actually correctly diagnosed what was going on. Probably kneecap the consultants with a 700-page report to say, we've already exonerated this nurse in an internal investigation, and we've got this report from a college that is 700 pages long. There are so many things wrong. And subsequently, quietly, the most amazing downgrade has happened there, in that it's been an upgrade to be downgraded. So they've gone from looking after babies that should have been looked after at a very high level, to doubling their consultant numbers, having a new build, and all to deal with much less cases, much less difficult cases, plus a big drop in the birth rate. And as you well know, there was infection, and one of the parents described how dirty the place was when they were sent to a room after the baby had died, and how grimy it was. So that's it. Yeah, if you look at the picture that I've shown you, how clean that is, an amazing environment that you have to get. You almost to get to the intrauterine level of cleanliness and alertness and awareness of what you're doing. And what struck me is that's progress. And what seemed to be happening there was the opposite. They were getting rid of their experienced staff who would point these things out, and they needed a college report to come and tell them.
Yeah.
So sorry to digress, but
that was me digressing.
All right. I'll blame you then.
Yeah, you can blame me. That's fine. Please continue.
So anyway, I'll just go on to the next slide. So I used to show these slides at a discrepancy meeting. I think it's worth showing them, and then we'll move on because it won't take long. So doing the Star Trek analogy. So to boldly go beyond merely pointing out discrepancies by learning from them, discerning any patterns of weaknesses, and I discern quite a lot of patterns of weakness. Very highly, the area around the pulmonary arteries in a chest X-ray is tiger country for missing things. But I was quite strong in that area, and I had different areas that I was weak in. Anyway, I then paid more attention to those. So communicating them to others as well. So it's not just your mistakes. You should learn from other people's mistakes. Then then that's symbiotic. You've increased your awareness by learning from other people at a meeting. Things to enable future prevention strategies, both for individual practitioners and organizations. So, and then we get to the retrospective scope, and this is the tool that's being used here. This is the thing that's being wielded, and they're getting it wrong anyway. So it's a powerful tool. You have to use it with respect. I mean, if somebody did a study in America, but it was a big veterans hospital in America. I don't know, is it the Reed Memorial or something? Anyway, huge number of veterans getting yearly chest X-rays, and everybody that was in that hospital who was diagnosed with cancer, had their previous X-rays looked out and examined, and the cancer was often visible on the previous X-rays. It just hadn't been picked up. And this is where the most of the American literature came. A chap called Berlin did most of the studies, if anybody's interested in looking at it. It's easy to Google and find. So what you do is, if somebody says, oh, there's a tumor, you look back at the previous and you say, oh, there it's there. Well, was that pickup? Was that? So then the accusations start to fly, and this is all about falsely accusing somebody. This is a false accusation. There was a national day or an international day of false accusation victims a week ago. But there's lots of people, I think the nurse in Glasgow is one, the nurse in Holland who got out, subsequently she died last week, I think. So you can go back and you can pinpoint it, because you just need to look at the centre of where a lump is, and there it's there. But that's not to say that you were at any fault for missing it at the time. So I've done cases where I've done an X-ray, 2 X-rays in the one day, or 1 X-ray and then 1 the next day, and you can see it in one examination, you can't see it in the other. Just exactly the same examination. Just depends if you breathe a wee bit. If there's a wee tumour, it'll lie over a rib and you won't see it, or it might just pop in between the ribs and you'll see it, or various number of reasons for it. But the radiological beatitude is normally, blessed is he who's last to the case, for they get the answer right. But in this case, there's a bit more digging to do, and I've done a wee bit of that, and maybe something of interest later when we get to near the end with the retrospective scope. So The causes of error, so basically the biggest one is observation errors. Do you perceive it? So that's a half of errors. And then the next one is interpretation. You see something, but you think, oh, that's just a benign tumor or something. You maybe see it, something that looks like it, or it mimics a disease, or a disease mimics something that looks benign. And diseases are great mimics. And then the next biggest item is communication. And if you, it's as I call, you get happy endings from happy beginnings. So if you get a good history and a good steer on what the problem is, as opposed to just sort of saying, I want a chest X-ray, and not giving any steer to the person who's interpreting it, you're not likely to get a very helpful report. And then the accuracy. Now, sometimes it can be with voice-activated dictation, but now got instead of secretaries, it can be missing out a no. Say there is a no, something, or a no gets put in. The voice-activated dictation, I've read it sometimes, and I think it's actually Shakespeare that I'm getting. I think I'm, certainly you get lots of weird phrases, and it's more difficult than having a secretary. And they got rid of the secretaries, the PA ones who were assessed agenda for change. And I reckon about a fifth of my week is now being a secretary. I'm not trained to be a secretary. I'm trained to be a radiologist. I'm trained to look at images. And they're paying me to be a secretary. And I, raised antibodies about it, but basically it went in a circle and I got nowhere. But those are the sort of things that detract from, they're a distraction from what you're doing. And, it's not good. So those are the main causes of error, and you can have a quiet reporting area, but it's difficult because you're in a clinical environment. People are coming and interrupting, asking for help with X, Y, and Z. And I used to just make time. I use my biology to my best endeavor. I even had a yoga mat in my office, and I would go and lie down, and I felt tired and become freshened by a nap, and then I'd be able to work again. And there were spells where we were caught out with thousands and thousands of films for reporting. So it was inexorable, and we did the best we could. But it takes 5 years to train radiologists. So the situation at one stage is 5 years behind the staffing coming through. Even if they accept it, they'll pay for the trainees to be done. So given the explosion of imaging that was being done, we're chronically working away. We're never up to date, and we have that in the background. And we know that we have to sort of compromise a wee bit. We just don't have enough. So anyway, so those were my practical improvement issues. So if you get happy introduction, hopefully you'll get a happy ending with a nice report that addresses the question that you did the examination to try and find out what was wrong. If you didn't say it at the start, you would think that would be a prerequisite, but you've no idea how many times the history is wrong. You look at the previous films, you have to take time and do that. So it's called radiology. It means the study of X-rays. And you don't do that quickly. You don't fire from the hip. It takes time. So you have to be realistic about how you can satisfy your search. If you see one abnormality, that's fine. That's the report. But you're looking at, I always think of it as like one of these where you have to get the difference between two images. So they'll say, spot the difference in the image, and they'll say there's 4 things. Well, you don't know how many there are on each of those 5,000 images. And you might have previous ones to look at as well, and you've got to look at them in the same way. So so there's always this problem about satisfaction of search. You could see 3 things, and there's a 4th lurking there. And you have to sort of find ways of overcoming these cognitive traps that somebody once labeled them, and they are. A brain can only take so much, and you have to sort of. I tended to use my biology as most effectively as I can when I was under pressure like that, and I had a very understanding leader, if you like, a clinical director, who realised that the department was getting a benefit from it, and I was getting a benefit from it, and it might have been not what everybody else was doing, but in some ways, I think it was better. I felt it was better, and I was getting better results, I suppose, is the way I saw it. So all the things that you can do, basically just to optimize your thing. So I just want to mention this reference, and it's way back. I thought it was 1912, but it was 1903, and it was a chap called Osler, very famous. He's got disease signs named after him. That's how famous he was.
Okay.
Osler's nodes. Anyway, I think he was originally trained in the UK, and he went to Toronto. That's where Shirley is, isn't it? So there you go.
Yeah, yeah.
So he gave this address on the Master Word in Medicine to the medical students on the occasion of the opening of the new laboratories in the medical faculty of the University of Toronto. And to cut a long story short, he went through. It was like how to join a monastery and things to do to concentrate in your work. So because the master word was work. So if you concentrated on working, you'd get good at it. Imagine that, Wish I'd read that at the start instead of finding it myself. Yeah. So anyway, the point being that if you want to be expert in anything, you want to have somebody, and this comes to witnesses as well. If you want to be expert in something, you have to do the work so that you know the pitfalls, you know the things that can trip people up, you know the things to be aware of, you know what to look for. Somebody gives you a story. Now in the discrepancy meeting, I listen to the story, and I can tell before they put the thing up what I'm looking for quite a lot of the time. Something I didn't have a number of years ago, So anyway, it's just experience. And this is the thing about Robinson. I've basically gone over it, but so a checklist and a double check are the two methods that you can use, and it's statistically significant with me. And I was a bit of an expert, in a loose term, because I did a lot of work. So I was an expert, and I double reported. But when I double reported, so if you're looking at a chest X-ray, you'll start looking from the outside in. You'll maybe look at the skin and the bones, then the lungs, then the heart. So what I did was I left it for a day, at least a day, with a report done, and I knew it was safe because there was nothing I needed to phone MD up about. And then I come back the next day, and I did the opposite. So I would start in the middle, so that I was trying to look at a new image, but with my same level, and that's how I managed to half the error rate in a nutshell. But then I realised when I was studying more about it that it's safety behaviour which trumps accuracy. You can get somebody that's more accurate, but they're unsafe because although they get a higher mark, they let dangerous things go, or they're not so good at the dangerous thing. So it's important to be aware of the clinical aspects or the clinical context of what you're doing so that you don't miss out things that you might reasonably be expected to be worried about or concerned about. So safety is more important really than the accuracy, which is more difficult to measure. And we're all aware of the Swiss cheese model. This developed from the airline industry, but adverse events run through holes in the care model in this instance, and it be the airline industry model in theirs. And you can enlarge the holes by removing what are called redundancies. So if you have Michelle on your unit, you've got redundancy built in that you've got young nurses who are being taught by her, and then she's got that. She's there as that person for them to go and ask if there's an issue. So if you remove them, that's taking away a mechanism of better. So in other words, I think what you're doing is you're widening the hole in the Swiss cheese, the holes. So someone who's got expertise, perspective, and can spot problems early can also spread good practice and increase knowledge. Or you can add a distraction to downgrade, as I say. So I end up doing secretarial work. It's de-skilling me because if I'm spending 1 day in 5 checking over things that should be done by somebody else, if you're doing 1,000 reports a month and you let the management take your secretary away, you've got a lot of checking to do, which is time off doing what you're trained to do. So, so as I say, we're doing 10,000 reports a year, and up to 1,000 images and looking at 5 standard settings, and not a very detailed CT is, it's a heap of work to get through. So the system that's used in the healthcare is the law of tort. So basically, the system can't be held at fault. Now, it started off because there was a snail in a ginger beer bottle. That's the original derivation of the medical negligence, what you might say, process. And surely that was a system that was at fault rather than one individual, depending on how much automation there was in the ginger beer making process. But that's how it came about.
Okay.
And doctors are often accused in that mainly falsely, because an awful lot of cases, people think, yeah, that would have made a difference. But in fact, to be honest about it, it doesn't make a difference a lot of the time. There's 3 basic things in the law of tort. You have to have a duty of care, so you have to be the doctor for that person. You have to have breached the duty of care, and it has to have caused damage, significant damage. And it's quite a hard, those are 3 hurdles that are quite difficult to circumvent in a legal process. But it's based on the ordinary, and doctors that are accused, they are a second victim. Nobody goes to work wanting to make a mistake or thinking they'll make a mistake and trying hard not to. And then if they make a mistake and somebody gets harmed, to err is human, but the secondary effects of being human are something as well. You become a second victim. If somebody dies because you've not been paying attention or something's happened, like say the person that had injected the air, the person had died, how would they feel? So, and it's difficult, and I'm thinking putting myself later on in these expert witnesses' shoes as well, from the same sort of perspective. But anyway, the standard is based on an ordinary skilled practitioner's performance inadequacy, and it's not 50%. It's basically on the balance of probabilities, although that's what it's supposed to be. But basically, if you pass an exam with a good rate, like 80%, you've not done well in 20% of those cases, and you might be the good one. But anyway, and the wee question I was just going to ask, I didn't know myself, so I just put it in the slide. I thought I'll dig that out later when I'm looking at there was a paper that you asked a question about, and I hadn't read it yet. But is the death in air embolism due to brain injury, because air gets into the brain and cuts off the control areas for vital processes, or is it just because there isn't enough oxygen getting through that the air is gumming up the lungs? So again, it's something I'm not sure how it happens, but anyway, move on. In the airlines, it's different. Reporting's mandatory. If you don't report things, then there are very severe penalties for non-compliance. You'll be dismissed. So it's very much safety first and foremost. And I think of a plate of ham and eggs when I think of the 2 systems. And you think for a plate of ham and eggs that the chicken is involved and the pig is committed to producing a plate of ham and eggs. Yeah. And, pilots and aircrews are committed in a special way. So the airline industry is particularly strong safety culture. And, that's the sort of gold standard, if you like. It was I think a lot of the work was done by an airline pilot who lost his wife in a crash or something. But so from a tragedy like that, he began to look at what could go wrong. But anyway, the legal fiscal system's not without its problems. And I've listed quite a number of things that are very, very public. And to me, it seems a bit strange that it's very conservative. Nothing seems to change. So, for example, expert witnesses in America have to be relevant to what they're giving. In a complex case, doesn't matter whether it's medical or whether it's IT or whatever, they have to be relevant to the actual case. And I'm not sure that the expert witnesses were all that, especially the main one, was all that relevant. But we get to the postmasters there at the bottom. And the big thing that changed changed the outlook there was the drama, the program with I think it was Alan, I can't remember his name, but it was played by Toby, the actor. And they picked the wrong guy when they started to accuse Alan of fraud, and he was fit for them, and he fought it. And the story of that's quite remarkable. How he managed to get a court system that basically assumed that you were guilty, and that's what they've let develop here happen in this Lucy Letby farrago of miscarriages. And it goes back. So we knew about the tainted blood scandal, and we knew blood was coming from American convicts way back in the 70s. It was in the British Medical Journal, leaders all the time. And the consultants who had to give the blood were trying to stop giving blood because they knew there was problems, and instead of sorting it out, they just never bothered. We all know the problems of all these other things. Wrongful accusation for Malkinson. They knew for years that the evidence exonerated him, and they kept him in prison for ages. Not a lot of people know about the pelvimetry. When I started, we used to x-ray pregnant women, big doses of radiation for their pregnancy. And it was so big, it became, the Oxford group studied it, and it became the second biggest database of radiation harm to children. So we were able to work out what the dose that caused childhood cancers was based on what you were exposed to. And that was from the atomic bomb survivors and the Oxford group. And looking back, it looks like it was a judicial system that kind of threw up their hands in horror that somebody didn't have a pelvimetry. And the word got around, and everybody started having pelvimetries. And we don't use it nowadays. It's one of those things that, so I class it as a medical legal issue rather than a medical one. But again, it's somebody knowing to say, hang on a minute, just put your fist in where the baby's coming out and measure it, with palpation rather than getting an X-ray. So anyway, this discussion's about leaders. I mean, is there a leader? I mean, you can see we've got colleges, and I don't know what the legal profession's got, but there doesn't seem to be any leadership. I mean, they're under political control, and that's all going to pot. The Lords is generally regarded as the sort of area for the legal system, and
Well, I do like regarding the first point. I listen to arguments that people who believe in the adversarial system make, but I find them very unconvincing. I just think it's existed for a very long time. Lawyers and barristers have become more and more sophisticated at knowing what our tactics work within that system. It's obviously evidence going into the system is getting more and more complex into what is an antiquated system, and I just can't argue in favor of it. I feel surely an inquisitorial approach would be better, surely.
Finding the truth out here is the most important thing. And that seems to be secondary to winning the case. It's all about winning the case. What's that all about? That's kind of macho stuff.
I mean, I always say, if you had aliens come down to Earth and dispassionately look at the system, and then you said to them, is this the best way of getting to the truth and the right result? Obviously, they would say no immediately.
Yes.
But because it's been in place for a long time, we just think, well, we'll just carry on because it's too much trouble to do anything else, basically.
Well, that's it. If you asked them to fix it, they would eventually, within a few days, they'd be shaking their head and think, no, you fix it.
Yeah.
we're going back.
Well, that's it. I mean, that is, of course, the problem. But I think we have to, one of the first things for me is that we have to accept fundamentally that if you make it, I'm going to analyze the Daily Mail podcast at some point soon, or I may have done it already as I'm recording this. This may go out after I've done it. But in that podcast, they're saying even Little is the most fervent defender of the system, is saying a court case is basically just a game that two sides try to play and win. How can that be? How can that be acceptable when you're talking about putting someone away for 15 life sentences?
Yeah.
It's just outrageous.
Hmm. I know it is. It's really outrageous. Now, I'm you know I'm trying to sort of get context here,
Mm.
and you know when you look at it, what's more, Occam's razors basically. The simplest explanation is usually the truth.
Yeah.
And you kind of you can do statistical, Bayesian things to do with epistemology, I think it's, or epistemology or whatever, about getting the truth and things like that. But in here, what's really striking is, again, we go back to this image from our hospital, and it's these children were dying.
Mm.
The ones that were these weren't unexplained. They were denied effective diagnosis and treatment. Reasonable assumption, right? For example, two children who needed a blood transfusion. It wasn't, it wasn't sussed. It wasn't diagnosed. We had a case in our area where a young fit person had an operation, and they were bleeding into their hospital bed, and they died from blood loss, and it was a young person. And what happens in a young person, and it's probably the same with the neonates, although it depends how much reserve they've got. But if you're suddenly at a stage where you're collapsing as a young person, you're probably too far gone.
Mm-hmm.
So you don't get any warning. So we know that one of the babies had a peripheral line, and the doctor really wasn't aware and kind of walked away, put a line and walked away. And sometimes there was babies not getting fluids that needed them for 8 and 12 hours. I mean, the other side of Lucy Letby, Michael McConville's series, it's almost like a teaching file
Mm.
for all this. It's a sort of learning from, well, I wouldn't call it discrepancy, but learning from adverse events. It's more than discrepancy. But anyway, so all the prematurity and serious pre-existing conditions. So if you look at the causes of sudden collapse, and I spoke to you before we came on that I'd lost the reference that I had for the guidelines for finding out what causes sudden collapse, and I found it, but I went back onto Google because I hadn't found it at that stage, and then I found a study from our hospital. I think it was the first ever done on that, and our rate of sudden collapse was exceptionally rare. It was 1 in 10,000 unexpected collapse. But that was because when you look at the figures, I was thinking, wow, that's really, that's very impressive. You look at the figures, there wasn't a single premature infant in that.
Right.
If premature, it's expected.
Mm.
So it depends in the context of what you're looking at. So you've got one paper on the one hand that's got a list of things that causes sudden collapse, and it's a systematic list, fair enough, but it's got caveats all around it, and it doesn't show, it doesn't show the caveats, highlight them often enough. But if you look hard enough, they're there. But you shouldn't have to look; it should be at the top, saying, "Look, if this baby's got pre-existing problems, it's premature." Growth retardation, or mum's had serious illness, or whatever. But so you have to take it in context.
Mm.
And yeah, another Toronto connection there as well. But anyway, so prematurity and serious pre-existing conditions like haemophilia. These were cases like that. Two babies needed blood transfusions and didn't get them. Filth in the hospital, the contamination that was there. And then something struck me, and I was looking at the Thorough Inquiry causes of death, and it went back to the chief witness, whose original thing was, oh, there's inflicted harm here after 10 minutes looking at some notes, and a noxious substance is administered. So I'm just going to run with that, right? So 6 different MOs, including some never heard of before as cause of death. So it looks like he's got a bit of variety here. You know, he's not just an expert in aortic embolism. He's got a few other tricks up his sleeves. He's putting Dexter in, or he's accusing Lucy of putting Dexter and Hannibal to shame here. You know, amateurs compared to a nurse just immediately thinking 6 different MOs.
Yeah.
And again, here we come to Occam's razor. What's more likely? You know, a really inventive mass murderer or, you know, poor care. Anyway, up until then, it was only evidence. The only evidence was coincidence. And no one saw any mistreatment over any of the cases, any of them. So, going back again. So what I'm going to do is consider, why didn't anybody consider cyanide poisoning by capsule biting? Right, no, well, I say cyanide poisoning, and the reason I put capsule biting is for a reason. It's just to work in a play on the words. Okay. But everybody thinks cyanide. Oh yeah, Heinrich Himmler committed suicide, and so did what's his name, Goering, with cyanide, and cheated the hangman. Da 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 da. So they were done in by cyanide, and it's actually quite common, cyanide poisoning. It's smoke inhalation, all these cyanide gases that are given off. So there's a similar pathway in biological terms to what was happening to these babies with cyanide. There's 1 or 2 differences, but I'll point them out. But so I got this reference from a paper. It's a simulation paper of how firemen deal with cyanide poisoning. Sorry, that's going backwards. Still going backwards. Right, there we go. So that's the reference. And I'd just like to point out that the police said that Lucy was an attention seeker. That was that in the video that they issued afterwards. So this was as near as a motive. Am I right? That's as near a motive as they had, was attention seeking.
As we're going to discuss, they made that claim that she wanted attention from the doctor.
Yeah.
No one had any motive. I think really, even in the court case, this was suggested in a very apologetic way, as if they didn't really think it had any merit.
Right. Okay. So anyway, so I'm going down to the common pathway again. Now I mentioned about mitochondria. So basically what cyanide does is it blocks the mitochondrial cytochrome pathway, the one that gives you all the energy, as does the acidosis from neglect, not being treated for being premature with problems adequately by people who are aware of what they need to treat. In a way similar to that incubator, the picture that shows of the care that's provided to that baby who's outside the womb. So, but basically, sorry for the typo, but he's not a pathologist, he's not a coroner, but he's able to countermand every single one of those people. He's not clinical neonatologist by training or tenure. In other words, he doesn't have the experience, even though, sometimes you can gain the training through experience, the work, the master work. He's not a forensic specialist. He's a general pediatrician with an over suspicion of Munchausen by proxy. And this is where I come back to the Thirlwell columns. So in the Thirlwell columns, the causes of death are given by the pathologist and the coroners. And then there's the next column, what happened in the criminal court. But there should be at least another 2 columns after that. What's the medical diagnosis? So the medical diagnosis isn't the cause of death. It's all consistent, and he doesn't change. It's the most consistent thing about it. It's Munchausen by proxy. Right, so here we go. So she wasn't there when insulin poisoning was alleged to have happened. So a dollop of Munchausen by proxy, there's a second bag that she's injected, and somebody magically has picked the right second bag and poisoned her while she's having a day off. So she's murdering on her day off. She's on holiday when that baby developed a lot of excess, the one where the famous dollop of air was added the next day that tilted the balance between life and death. So again, another dollop of Munchausen by proxy. So air in the NG tube. And there were 3 other people in the room at the time when it happened, and they saw nothing. And then a ruptured liver after a birth injury, and then paracentesis into her right abdomen and loss of half of the blood volume. So that dollop of Munchausen by proxy is a punch without bruising on the surface. So back to the image, which I'll probably talk to for a wee while if that's okay with you.
Yeah, fine.
Okay. So an image, they say, is worth 1,000 words. So what you've got here is a complex arrangement, a real pile of work, huge amount of work, twice the size of what you saw there rocked me when I saw it. So I asked the permission for the photograph, but how could the experts hone down, and they all quickly hone down. If I was going to give information, if I was going to give evidence in a trial like that, and somebody said, what are the causes of collapse? I'd be getting them to demur as much as possible. And you know, it's almost like I don't want them to mention air embolism because it's so rare. I don't want to be seen to be going straight in there. But he seems to have been able to get everyone to sort of quickly hone down on air embolism for some reason, of which there's no evidence. There might be air seen on an X-ray, but as I said to you, we are beings of cavities and tissue planes and blood vessels that carry liquids, and that includes air. So it's very difficult in a plane. I mean, the X-ray that's in the Lee Tanswell has got air in other systems, but you can't resolve it. You can't see clearly. You can only see the systemic venous system, which is actually part of the pulmonary circulation. But there are myriads of other vessels involved and other systems involved in it. So the actual conditions are as described. There were serious pre-existing maternal and fetal conditions for this, for these infants, and they were basically looked at in a sort of general pediatric setup. So it wasn't equipped to deal with them. They cleared out the nurse practitioners. They let the place become not very clean. And when you look at that picture, you see the cleanliness that's involved in it and the care that's involved in it. So this baby, I didn't show, it's fighting, it's got an endotracheal tube down, it's fighting for its life, basically. It's got a fight in its hands. If you take it like a boxing analogy, you know, it's got good people in its corner fighting for it. So all I know now is when I see that picture, I think here and now, that baby's got very significant assistance from staff of 12 full-time neonatologists. Just imagine that. These people live and breathe their vocation, their specialist vocation. 12 of them are looking after that baby in turn. And included within that group, 2 very smart professors. And there's many, not just the consultants, but some of the trainees are at 7-year level, are totally aware of things, and they've maybe done several years in the neonatal unit on rotation. So they're all aware. And then they're supported by a team like the transport team. Now, we all know how much the transport team was held in awe when they appeared at the Countess of Chester and started doing things. So we've got a transport team as well, and they come. And then you've got visiting consultants, neurologists, neurosurgeons, general surgeons, people for gastroenterological problems, and that's not even the nurses and the skill mix. And the first thing that struck me when I arrived in my consultant post to do a scan of a pregnant woman was that I was getting evaluated from behind by a person who was supposed to be lesser in rank than me, but whenever I did the examination correctly, I could hear a sigh of relief behind me. Right, okay, we've got somebody in charge that perhaps knows what they're doing. But that person was a product of skill mix. And then when you look at the nurses, the senior nurses, there's different levels of nurses that are there. They're training each other. There's the paramedical support, all the X-ray staff, the visiting consultant, who shall be nameless, and others, the consultants from the Sick Children's Hospital, who come and have case discussion meetings. So that meetings, I go to that weekly, and it's always getting interrupted by somebody coming in and saying, "Oh, there's a baby out there that's hypoglycemic and cot 6 or whatever," and somebody will have to leave and go and get it sorted. So all these episodes of hypoglycemia that you hear with the insulin case and how it's been put into disrepute is in context of the hospital. And every time you go to the X-ray meeting, there's a CPAP belly on the screen and nobody comments on it. There's huge amounts of gas in the abdomen. And it's only the cases where there's small amounts that can make the diagnosis of necrotizing enterocolitis. Again, significant diagnosis, not mentioned. Why weren't all these conditions mentioned by the expert witnesses? When I say conditions, I don't mean pathological conditions. I mean the conditions of care. So, so there's clinical chemists, genetics, physiotherapy. The secretaries and the clerical team do a fantastic job as well. And even the store person and all the staff, and the cleaners especially, the cleaners, they're always cleaning. You're always having to watch out you don't trip because the floor's been constantly cleaned, constantly mopped. And it's the best designed unit in the hospital, ITUs. It's a whole line of them. And they've taken so much care to design it for cleanliness, for washing hands. And that's what's in that baby's corner. And that's why the babies do so well, I think, in the unit. So it conjures up to me a clean, caring, and professional environment. And I think as well, when I look at it, I think if it wasn't for Shu Lee being outraged by this paper and being able to command a world team of experts from, people equivalent to my colleagues who are looking after this baby, the chances of being as far on as we are probably about a 50th of where we are just now, where it's accepted that there isn't really any scientific dubiety about this. It's all about people's perceptions. They've all had a huge publicity. So the post office people were all in the communities. There wasn't a big national trial to say, these postmasters are all guilty of embezzlement and have betrayed their community and things like that. Whereas this was filmed. But Cliff Richard, that's a bad omen for a prosecution having that as a thing, because he was innocent as well. So they had it filmed, and then they dug up the garden so that even when she was anonymous, as if she was taking babies home to do what? I don't know. Anyway, so it's just the picture is the philosophical opposite of progress. That's what progress looks like. And they were putting a peripheral line in, just a wee tiny line in a baby's arm or wherever. And that was supposed to be a substitute for all of this. And then they would walk away. You read the stories from Michael McConville of what they did. They just weren't aware. Now, that's because they weren't trained. That's just the circumstances that were in. This is when you go to specialist or generalist. There's a difference, and if you're judging a generalist, you shouldn't be using a specialist and vice versa. So again, it's appropriateness of what the things. So, and again, the warnings. Where are the warnings from appraisals? What were they doing in their appraisals? What were they doing?
I mean, I can't answer that question, but
well, no, I'm giving you an impossible answer.
it's clear that something was going fundamentally wrong, isn't it? With the
yeah. So, and obviously the choice of witnesses. Now, even for an X-ray witness, I googled the radiologist witness, and he doesn't mention his clinical work. It's all about dead babies and doing MRIs, and he's a specialist for neurology. In other words, the head. And there's none of these cases are really anything to do with the head, as far as we know. So, wouldn't you be better with a practicing neonatologist, somebody like one of our staff?
So I've got a question for you. Okay.
Right. Mm-hmm.
So I came into this blind, obviously, and I've learned a lot over the last 2 years. But one of the things from the start for me is I can't understand how you can have a neonatal unit that is dealing exclusively with neonates, but you don't have a neonatologist. So I mean, how is that possible?
Well, I can't answer that either.